I want to thank everyone for coming, and I would like to thank our panelists for sharing their time and their expertise with us today. This panel is going to be discussing facts and myths around obsessive compulsive disorder, and I'm going to let each of our panelists tell you a statement about themselves and the setting in which they work and how they bring their expertise to the table today. So in order of appearance on my screen, I'm going to begin with Dr. Maria Mancebo.
Hi, I'm Maria Mancebo. I'm a clinical psychologist at Butler Hospital. I run the OCD and anxiety intensive outpatient program at Butler. I've also been doing research through Butler Hospital and Brown University on the long-term course of OCD and anxiety, as well as the implementation and effectiveness of exposure therapies for OCD in clinical settings.
Thank you. And Dr. Kimberly Chapone.
Hi, I'm Kim Chapone. I'm a psychiatrist at Butler Hospital. I work with Dr. Mancebo and Dr. McLaughlin. I work in outpatient and the IOP, and have been working with folks with OCD since residency. So it's been a little longer than I'd like to admit, but I graduated in 2007. So it's been a passion of mine to work with folks with OCD for a number of years now.
Thank you. And Dr. McLaughlin.
Sure. So I'm a neuropsychologist and the director of psychiatric neurosurgery at Butler Hospital. I also run our inpatient and partial hospital neuropsychology consultation service. And I also do research on OCD. And that research is primarily focused on neurocircuitry-based interventions for OCD. And so that includes deep brain stimulation, lesion procedures for patients with severe OCD, as well as transcranial magnetic stimulation and other types of non-invasive stimulation, and looking at cognitive and neuroimaging changes after those procedures.
Thank you. So we selected this topic today because obsessive compulsive disorder is one diagnosis that I think carries a lot of misunderstanding around it. So we were looking for experts who could speak to us more about what is fact, what is myth, and some of the stereotypes that surround OCD. So if we could begin by, if you could all just speak to basically just signs and symptoms of OCD, and at what point would you recommend that folks get help for themselves or suggest help for someone else? Like at what point is it serious enough to require treatment or not? Anyone may begin.
So who wants to start? I think all of us could answer this question. So
I'm going to nominate you.
Me?
Yes,
So,
please.
Sure, I'm happy to. And then Dr. Mancebo and Dr. Chapone, feel free to jump in as we're going through. So OCD is a very heterogeneous disorder. So it typically consists of obsessions, which are intrusive thoughts that cause distress or anxiety in some way. So, that could be something bad's going to happen, something's uncomfortable, and this thought gets stuck in someone's head. And then there's compulsions, which are behaviors that are typically done in order to reduce that discomfort or that anxiety associated with that thought. And as I noted, OCD is really heterogeneous. So you may see things out in kind of the general media about, oh, well, if someone has contamination concerns, that's OCD. And that's true. People with OCD can have worries about getting sick or worries about something bad happening, but OCD can present in many different forms. So it could be worries about something bad happening. It could be intrusive thoughts about hurting themselves or someone else. It could be concerns about, getting stuck on a part of their, part of their appearance. It could just be feelings of something's not right in a certain situation, that then they have to do something a certain number of times or a certain way in order to reduce that discomfort. So ultimately, there's many different ways that OCD can present. And we tend to think of this in a couple different, basically often 5 different subtypes related to OCD symptoms, some of which I just talked about. And I think the biggest question, and we'll have Dr. Mancebo and Dr. Chapone elaborate on that as well, but I think the biggest thing that we often say is when you should seek treatment essentially when something's getting in the way. So with OCD, right, when it's interfering with functioning in some way. And so that could mean that could mean many different things, right? So it could be slowing you down. So you're spending an extra half an hour to an hour at school or at work because you're engaging in compulsions or having thoughts that are distracting you from activities, right? It's causing you significant distress in some way. And there's not really any drawback necessarily going help or getting an assessment to figure out what's going on and what could improve the symptoms, whether it be with therapy or medication, and getting some assistance there. And I think when we talk about any psychiatric disorder, it's always when it's getting in the way, when it's interfering with functioning. And that's the same case here. And we often say, you know, sometimes I use a cutoff of like, well, when it's affecting you more than an hour a day, right? But that's not a hard and fast rule. It's where it's getting in the way. A lot of us might have things that we do certain times during the day. It's not unusual for people in the general population to say, oh, well, I check my car locks 3 times, right? And that's not a big deal if it's taking up about a minute of your time, right? But when something's occupying, you know, an hour a day, or again, it's slowing you down or stopping you from doing things that you really want to do, then we often suggest getting treatment.
Thank you. Doctors Chapone and Mancibo, would you like to add on to that?
Yeah, no, I the only thing I would add is that there is often something that delays getting help is the stigma and the shame that people feel about the intrusive thoughts. And especially the thoughts that are not your typical OCD symptoms. So for example, taboo thoughts, which are intrusive thoughts about hurting yourself or loved ones, as well as sexual obsessions that don't make sense to you. You just keep having these intrusive thoughts pop into your head. There's an incredible amount of shame around that, and people are often confused when it starts to happen. It usually onsets around adolescence or early childhood. So at that point, you know, people will live with these symptoms for a really long time before even disclosing it to someone that they trust. I think it's great that you invited us to this panel, because the more that we can do to help people understand the symptoms, then they can recognize it earlier on in the course and seek treatment earlier on in the course. The other thing is that sometimes the compulsions can be mental, so that you don't necessarily, you may have someone who's suffering with OCD and not know it because you don't see their compulsions. They're doing things in their head to try to neutralize the thought or turn a bad thought into a good thought. And so it may look like they're just being, they're daydreaming, or they're not paying attention, and they could be experiencing OCD symptoms.
I like to think of OCD as sort of a doubting disorder. So almost anything you could get caught up in doubt around, you know, what if thoughts, what if fears, you know, what if I strangled my dog? What if I hit somebody with my car? What if that doorknob has blood on it? You know, what if I step on a crack and I really do break my mother's back? Sort of, you know, these doubts, these fears that can pop up and really can latch on to anything. You know, what if I do something sinful? What if I do something offensive to God? And then compulsions are basically, they're not pleasurable. So sometimes people come in and they'll say like, oh, I compulsively shop, or people use the word compulsive around things that we in the OCD world wouldn't call necessarily compulsive, but more impulsive, like something that's kind of, you know, maybe not the best for you, but there's a pleasure component, you know, like gambling or, you know, spending and things. So compulsions really are meant to make you feel less anxious about that obsessive fear. You know, so what if I left the door unlocked, even though I pretty clearly remember checking that door 6 times, but what if that last time I didn't hear it click all the way? What if then somebody breaks into my house? So then the compulsion might be to go and check the door, or mentally replay them, you know, the memory of them locking it, or checking that their dog is safe or their kids are safe, or driving back where they just drove through to make sure there are no dead bodies in the street, for example, or they might avoid is another compulsion. So avoiding driving by schools because they don't want to drive near children, because what if I hit a child? Or avoiding changing the baby's diaper because what if I touch the baby inappropriately? So that's another common avoidance that people don't think of, or common compulsion that people don't think of as a compulsion. I know one of the things that you sent us about, like some talking points were like, you know, do you have to have compulsions? Can people just be primarily, obsessive? And, I think that can be a thing, but I think more often when I talk to people that say, oh, I have pure O, like pure obsessions, they're usually doing some compulsive behaviors. They're just not thinking of as compulsions, like mental counting, mental praying, mental repeating, replaying conversations in their head to make sure they didn't blurt out something obscene, or avoiding. And those we would consider compulsive. So I think most often, in the majority of the times, there is a compulsive component.
We had a question in our question box from one of the attendees asking, what is the relation of OCD, of intrusive thoughts that happen once in a while, as opposed to an ongoing?
So like Dr. McLaughlin said, I would say generally it meets the criteria for OCD if it's causing a lot of distress day to day, or we'll, say does it take up an hour a day? It can some people get really focused on one type of fear, contamination fears, for example, and other people it can sort of change over time, but it's not usually changing day to day so much. Mm-hmm. And there's generally like an intensity of the symptoms, like a severity, where day to day it's causing distress and taking up a lot of time. So we all have intrusive thoughts. Sometimes we all have, and they've done studies about that it's not that people with OCD have really different fears than other people. It's just they got caught up in them more. So we all get caught up in doubts sometimes. It's just more like, is it taking over your world? Is it taking over your day? That's what I would say. I don't know if anyone else would like to add to that.
I agree with that. And, that's what we're referencing earlier, and just what Dr. Chapon said. If you have an intrusive thought every once in a while, that's pretty normal. Most of us have a thought once in a while of like, okay, even thoughts like Dr. Manzibo was talking about that may make you feel really uncomfortable. Like, what if I drop my kid down the stairs, right? Which is not an unusual thought, especially after someone has a child, right? But it's a horrible thought. It's horrible to feel that way, and it can make you feel really shameful, as Dr. Manzibo was noting, but it's not an uncommon fear. The difference is, right, when I see a patient with OCD who says, I'm worried about dropping my kiddo down the stairs, so therefore I do not go near them, and I do not touch them, and I do not interact with them, right? And that's kind of the difference there, right? Are you kind of going about your normal activities and taking care of things the way that you need to? Or is it really interfering with either what you need to get done, or causing a lot of distress, or, taking up a lot of time in your day on a regular basis? And most people with OCD is typically considered a chronic illness, but it can wax and wane. So we can see times where symptoms may be a little bit less, and then times when they may get a bit exacerbated. But in general, for people who are still symptomatic, those symptoms are usually there, but they may go up and down over time. But one thought every so often, would not an OCD diagnosis make necessarily. But again, if someone's questioning it, I would say seek out assistance and get an evaluation.
Sure. Thank you. What are some common treatments and common therapies that are used, or what are the most common? I'm sure there are many. What are the most common treatments? Dr. McLaughlin, you're still on my screen, so if I could begin with you.
Well, I'm actually going to pass this off to our other panelists because, and I'm happy to come up kind of last, but I think the first line treatments are typically considered, behavioral treatments. So exposure and response prevention or ritual prevention, as well as pharmacotherapy. And Dr. Manzibo is an expert in those behavioral interventions. So I'm going to pass that off to her to start.
Thank you.
Yeah. So, what are the most common types of psychotherapies versus what are the most effective, or actually two different things, because we see a lot of people who've been in psychotherapy for a long time, and OCD does not respond to talk therapies in the way that many other depressive or anxiety disorders might. So there are people who've been in psychotherapy many years, but have never had any cognitive behavior therapy. And that's really the most effective type of treatment for OCD, hands down. If you look at the literature, you can compare one specific type of cognitive behavior therapy called exposure and response prevention. If you compare exposure and response prevention, the way it's intended to be delivered to relaxation therapy, to CBT, anxiety management strategies that typically work for anxiety disorders, exposure and response prevention is much more effective. So about 60 to 70% of people who complete a trial of exposure and response prevention are much better at the end of treatment. If you are unable to tolerate exposure and response prevention, there are cognitive strategies that are helpful for OCD. Usually it's working on the distorted thinking, including behavioral experiments or any other psychotherapy technique to get the person to reduce their avoidance behaviors or be able to cope with the intrusive thoughts without their rituals. There is some data to show that certain cognitive strategies like Socratic questioning. Lots of CBT therapists use Socratic questioning during their sessions, and it's actually not effective for OCD. And the reason why is because people with OCD realize that their obsessions don't make sense and they're unreasonable. And that is what Socratic questioning is intended to do, is to help people understand. And so sometimes it becomes a compulsion to try to disprove the obsessions. And what we try to do in exposure therapy is have them just be able to tolerate intrusive thoughts and let them pass. And that's a very different strategy than just talking and reasoning with people.
And then medication-wise, yeah. So we typically use antidepressant medications like Prozac, SSRI antidepressants as sort of the core medication for OCD. It also helps with, depression, other anxiety issues like panic disorder. So that can be helpful, because often people with OCD also have other conditions such as depression or anxiety disorders like panic. So usually with OCD, we often need to dose a little bit higher than we do for depression. So somebody might do well with 20 or 40 milligrams of Prozac, for example, for depression, but they might need 60 or 80 or even, super max doses of SSRIs to help like fully, get the same results for OCD. So it can be a little bit of a stickier disorder to treat and take a little bit longer to get the antidepressants to kind of work for them. We also use add-on medications to antidepressants if needed, and there's a whole variety of those, some that target, try to minimize the intensity of the intrusive thoughts or anxiety more generally. Or if somebody's really struggling with depression, we might try to go. So there's a whole range of different medication approaches, but usually the person with OCD, there is like an antidepressant at the core. And then I tend to think of like the others as more like helpers. And then, I know Dr. McLaughlin is studying, other approaches as well. So there's also, TMS for OCD, there's neuromodulatory interventions for people that are really struggling to respond to therapy and medications for their symptoms and have very severe illness. So that's my segue to you, Dr. McLaughlin.
And I would also just note that I think it really is important, as Dr. Mancebo and Dr. Chapone noted, it's not necessarily kind of run-of-the-mill therapy or run-of-the-mill pharmacotherapy. And so having someone who really knows what they're doing with OCD is really important, whether it be on the therapy side or the medication side, because if you haven't had experience working with OCD, you may not have the necessary training to be able to do the types of techniques that are needed for the for CBT. And on the med side as well, as Dr. Chapon mentioned, some, I'm not an MD, but so I will defer to her if she has additional comments. But what I've typically seen, if someone is even going to a psychiatrist, if that psychiatrist doesn't have extensive OCD experience, they may be actually hesitant to push those doses or try some of the alternative medications that are typically used adjuncts to exercise. So I think it's important for someone to at least have a consultation with someone who does have expertise in working with OCD patients on either side. And that, as Dr. Chapon mentioned, we do have some other treatments that are relatively newer treatments, although, so transcranial magnetic stimulation, or TMS, is a newer treatment. It is FDA cleared for OCD treatment at a specific target in the brain. And so TMS has been approved for depression for a while. The brain target that's used in OCD is a different target than that used in depression. And, we're pushing forward to try to get insurance coverage for that. It's a little tricky now because it's a relatively newer treatment. But hopefully we have that as a treatment at Butler, for example, in the near future. And I'm happy to talk more about specifics. We also, as I noted, I run our psychiatric nursery program. So for patients who have really failed all other treatments, and that means that they have actually participated in exposure and response prevention for a certain number of sessions. They've had a number of medication trials, and really nothing has been effective. And there are really severe treatment resistant patients. Then moving to something that's more invasive, like deep brain stimulation or lesion procedures for OCD, can be the next step in certain a subset of cases.
I think you're muted. Beth, you're muted.
Thank you. As I'm talking to myself. So one thing that we had looked at as a question prior to this that folks had submitted information or feedback about was common assumptions about OCD, and how people make the assumption that perhaps OCD is germophobia or compulsive cleaning or things of those specific nature. And why are those assumptions, rather than having a broader understanding of OCD, why is that misleading, and how is that damaging to people who do experience OCD? I don't know who would like to begin.
I think it's hard because those are common issues for folks. Fears around catching an illness, or kind of being a perfectionist. You sort of, and there've been, TV shows with characters who have OCD who display those kinds of behaviors. And so I think that's like in the people are more aware of those types of symptoms, whereas like harm or sexual obsessions, people don't really know about those, or even like, praying rituals or other things that are quite common as well, are just not out in the, in the public consciousness quite so much. So I think it's tricky too, because often people will say things like, oh, I'm so OCD about X, Y, and Z. And they're saying it in it's nice in some ways that people are talking about these things, and there's overall less stigma than there used to be perhaps, but it can be painful for, OCD can be a very painful disorder. And so if you're saying it in sort of a flip, casual way, and you actually don't have OCD, or saying like, oh, I wish I had OCD and I kept my house cleaner, like, it's actually a really painful condition. So it can make people, and I've had patients say this to me, that they feel angered or hurt when people say things like that, like, you have no idea like how much I suffer with this. And so I think that can be, can be harmful, both just not understanding all the various ways that it can present and the level of suffering that it can cause.
And I do think that those ones that you're mentioning, so like contamination, I think some of those have more obvious compulsions or rituals associated with them too. And so people make that, right? So they see that their family member or someone they're with or something is washing their hands excessively, or using hand sanitizer excessively, or avoiding things, not touching things that they don't want to become contaminated with, is kind of in some ways often more of an obvious symptom. Whereas, as Dr. Manciba was referencing earlier, a lot of our patients with OCD have mental rituals. And so they can be constantly thinking of things in their head, or redoing things in their head, and having a constant kind of background noise, essentially, of both thoughts and rituals or compulsions that no one can see, right? So even, I've had patients who, I work with a lot of patients with very severe illness, who some of whom are not able to function. And, or if they are able to function, they may be not functioning to their optimal ability. And, and they'll say to me, well, so-and-so doesn't realize that I have such severe symptoms, because they're still able to kind of get the things done they need to get done. And everything's happening in their head, and people can't see that, but it doesn't mean it's not extremely distressing. And just because you can't see it doesn't mean it's not happening. And they may be get kind of unsure about how to share that with someone when those symptoms may, again, come across as stigmatizing or shameful. And if someone can't see it, then the other person automatically assumes that it may not be so severe.
Mm-hmm. Thank you for that. That leads me to another question that had been submitted by one of our members ahead of time. And they asked if we could address co-occurring diagnosis with other sorts of thought disorders, for example, schizophrenia, and how those two co-occurring situations might be going on. If you could describe if you've ever had patients or done research related to the overlap of those conditions.
I can start with this one. So behaviorally, we're actually, I have done some research with community mental health centers where most of the clients in the study had a severe mental illness like schizophrenia or schizoaffective disorder, or bipolar disorder. But in my experience in the community mental health centers, they're very good at stabilizing those symptoms, because those symptoms get people into trouble, and they just receive more attention. Once the psychotic symptoms or the manic symptoms are stable, then you're able to do very good work behaviorally with OCD symptoms if the person recognizes that the symptoms are excessive. What is a little harder to treat is when there are delusions present or manic episodes, and the person just isn't able to engage in exposure therapy. So they actually believe that something bad, will happen, and someone is, for example, I had a client who thought that the government was watching them, and had all these compulsions, these checking compulsions, but you would treat that differently than someone who is just worried that something bad might happen if they don't check their stove. So if you kind of have to sequence the treatments. If you're doing behavioral therapy, work on the manic and the psychotic symptoms first until they can engage. Depression's a little bit different. People with severe depression, if you can get them to engage in exposure and response prevention, then, and if the depression is secondary to OCD, then you can see both the depression and the OCD improve with exposure and response prevention. But many patients just can't engage in the exposure therapy if their depression is too severe. So again, then you would need to treat the depression to a point where they're able to engage in exposure treatment.
Can I just add another, like a part two to the question is there some sort of, or some level of pharmacological challenge when you have medications for one of those diagnoses and for the other? Do they interact with one another?
Yeah, so I think the biggest problem probably is if someone has co-occurring bipolar disorder, because like I said, the mainstay of the core treatment for OCD is typically an antidepressant, which could destabilize someone with bipolar disorder. And so what we like Dr. Mancebo was saying, we usually try to stabilize the bipolar disorder with a mood stabilizer, try to get that under as good control as possible. And then, ideally we try to use exposure therapy, which wouldn't, have the risks of causing mania or agitation like an antidepressant would. But we sometimes carefully add an antidepressant as long as the person's on a stable regimen with a mood stabilizer. But there's some risk there. So that can be a little tricky, especially if someone has really brittle bipolar disorder and they're sensitive to, and sometimes for some people, we just can't use antidepressants safely and have to kind of go a different route. I think with things like schizophrenia or depression, there is an overlap in some of the the medications that we use for OCD can treat depression, can treat other, anxiety issues. So sometimes you can, that's not like you can kind of kill two birds with one stone with that. It can be tricky with people who have delusions or when like the OCD drives the schizophrenia and vice versa. You can sort of see the two kind of meld with each other. And it's hard. It's always hard. Some people with OCD don't have great insight that their symptoms are part of the OCD and they get caught up in them. And that's always a little harder to treat. So with schizophrenia, if they have delusional intensity thinking, they don't have the insight that these fears are not actually true, that they're part of their illness. They believe that these things are true. And so it's harder to do exposure-based treatment or challenge them because they really believe through and through that these things are actually happening. And so the idea of like, well, why wouldn't I have to check the doors, I have to do these things, or I'm not going to be safe. And so it's harder to argue with that, whereas someone with OCD with good insight can say like, I know this doesn't make sense, I know I'm worrying about this too much, I know, and then you can work with that, so yeah.
We had a question in the question box. Are there really obvious or really clear warning signs or symptoms that are often observed in many cases or the majority of cases that someone could look for?
For somebody developing OCD?
Yes,
yeah. I mean, I think getting caught up in repetitive behaviors, going in and out of doors or washing excessively or doing things again and again and again is a classic kind of outward sign. Like someone's getting caught up in a loop and they can't seem to pull away. It's taking a long time to get out the door because they have these rituals they have to complete, or taking a long time to get to bed because they have these rituals they have to complete before they go to bed. Like if there's sort of a sense that they have to do these things and it's crossing the line into like, this is taking a little too long, or you're doing this too many times. That's one thing I would say. I don't know what you all think.
Does anyone want to add?
I would agree. No, I would agree with that. I think, again, sometimes it's hard. It's easy to overlook or miss things because it's not always so obvious. But looking for even things like avoidance, I see, kids and adults, and parents don't always recognize this, right? So my kid doesn't want to do the dishes, right? And the parents saying, well, they just don't want to do the dishes because they're, a tween or a teenager and they just are trying to avoid it. But then when I ask them, they said, no, they're gross, they're disgusting, I can't touch them, or I can't take out the trash because I can't touch that, like I'll get contaminated. And so, but the parents don't necessarily recognize that. They may see that as oppositional when it may be anxiety based. And I think that also happens a lot in kids, is that sometimes when there's behavioral outbursts, digging a little bit deeper as to where that's coming from, because a lot of the kids that I see for evaluation, that's stemming from, not always, but stemming from anxiety or sometimes OCD type thoughts that then cause significant distress, and kiddos don't know how to handle that. And so often it results in an outburst. So there may be things that, you may easily attribute to looking like something else, but, having someone either, if a parent's not equipped to do this because they may not have an understanding of these different pieces of these types of OCD that we talked about, that having, seeking out assistance and getting a really good evaluation as to what's going on, whether it be for a kiddo or an adult.
Dr. Mancebo, did you want to add as well?
I agree with both Dr. Chapone and Dr. McLaughlin. The only thing is sometimes there's like, if you think you might have OCD symptoms, if you go to the IOCDF website, there's a little online test that sometimes people take. There's a checklist of symptoms. Often when we give that to patients, they will recognize things that they've been doing for a really long time that they didn't realize was OCD. So just seeing it on paper sometimes can help the person identify symptoms.
And I would say, speaking up, as Dr. Mancebo was mentioning, right? So sometimes people present, when she was talking about the community health center, people will present with schizophrenia. Even on our inpatient service, people will not necessarily present for OCD directly. They will present often for depression or suicidality. But that actually the kind of inherent piece behind this, they actually have really severe OCD or anxiety symptoms that then may lead to depression. That's what gets them in the hospital. And no one asks them the questions about, intrusive thoughts or behaviors or anything like that until someone kind of covers the bases and asks them all those questions. So if someone, is having these thoughts, really just to make sure to speak out, even if they're seeing someone currently, if they haven't kind of talked about some of these symptoms, to talk about with them, and then they can kind of help get a better assessment of what's going on.
I've had a couple of questions submitted prior and in the chat box asking, what are ways that you can help a loved one, or what are things, conversely, that are not helpful when you are trying to assist somebody and get them support? What are things you can and shouldn't do?
I can start with what you shouldn't do. So just telling someone to stop it. Sometimes, you see somebody washing their hands over and over, or checking over and over, and you get very frustrated because they can't stop. So expecting them to be able to stop is something that can just impact your relationship with your loved one, rather than getting them to get help. Being able to talk to them when they're calm and asking them, what I noticed that it took you a long time to get into the car today when we were trying to leave for school, or when we were going out to dinner. What was going on? Just trying to approach it in sort of an empathic way, in a curious way, rather than addressing it when feelings may be high and the person may be distressed. It may be less productive to talk about that then. The other thing that family members have really good intentions sometimes, but will end up doing is accommodating the OCD symptoms. So by that we mean, if someone doesn't want to or is unable to unload the dishwasher or take out the trash, then because it's so distressing for them, we may just say, you know what, I'll do that, you do this. But if that list starts to grow and grow, then that might be reinforcing the OCD and the avoidance behaviors. If someone's having trouble going into the supermarket, or going to school, or going to work, and you start to sort of accommodate that because the person is a really nice person, and you see that they're clearly distressed and they can still do their work, or they can still do their schoolwork, you may inadvertently be reinforcing their symptoms. So that's just.
No, and I agree with that. And we see that a lot with, especially things like reassurance seeking, whether it be with kids or adults. I see a lot of kids who will bring their parents into their compulsions, for example, like the parents have to say certain things before they go to sleep, or they can't go to sleep. But the problem is that those things then tend to escalate. It's not 3 words. It sometimes escalates into very specific routines before bed that can't be carried out, or have to be carried out by a specific person. And if that person is not there that night, then the bedtime routine is completely thrown off. Or frequent texting of a parent or other family member saying, like, where are you? What's going on? Is this okay? What's going to happen? Like, again, we call that kind of reassurance seeking, and that accommodation can then, again, kind of reinforce those behaviors. But it's really hard, as Dr. Mancebo mentioned, when you see a family member or a friend in distress, right? And you, especially a child, and you want to make them feel better because they're, and also just, it makes the household easier to run, right? So if you have someone in your household, especially a kiddo, if you have an 8-year-old who's flipping out at bedtime because you don't do that routine, you're going to do the routine potentially because it makes it easier, because otherwise, everyone gets disrupted. But ultimately, I think that working with a therapist to learn, okay, at what point do I step back? What point do I push? And working with the therapist to come up with a plan in that situation, if that person is seeking out treatment, is really important.
And the other thing, there's a book that I really like. It's called Loving Someone with OCD. And so that's an excellent resource for family members, because you can read about the language that you can use to talk to your loved one. If it's somebody who does not recognize that they have a problem, then there are interventions for family members, doing like a family contract around their OCD and how to limit its impact on the family or on daily routines. So that's just another resource.
Thank you. That said, where would one start if they themselves or if someone they love needs help? Where to begin? Do you go online to find a therapist? What is the first step?
So that website that you listed in the chat, IOCDF, is my go-to. They just have an incredible, they've been around for as long as I can remember. And they just have an incredible amount of resources there for patients, for providers, for family members. They do, since COVID, they've been doing a lot of virtual sessions. They do an annual conference that is a nice mix of people with OCD, as well as family members and professionals and specialists and researchers. So I think they're back to in-person this year, but they've been virtual throughout COVID. So I think more people were able to attend. But the International OCD Foundation is a great place to start. And there is a therapist directory on that site.
Many of the states, I don't know about all of them, have IOCDF branches. So like there's one in Rhode Island, that's OCD Rhode Island, that has a Facebook group that even within Rhode Island, I've spoken, done talks like this. And so there's other ways to get information, and there's specific topics every month, and other states do the same thing. So that's another kind of extension of the IOCDF, but that's my go-to resource as well. And there's also, there's ways to find providers on there who specialize in OCD. And so if you go onto that website, there's ways to get help locally. And so I also use that as a resource because we get calls from people around the United States looking for, usually coming for neurosurgical options. And so we will also send them to that and help them find local resources too.
Great, thank you. Can you all speak about what is new in research, treatment, what developments are out there that are cutting edge or hot topic right now?
Do you want me to go first? So we talked a little bit about TMS for OCD. So that's one of the kind of newer FDA cleared treatments for OCD. And again, that's transcranial magnetic stimulation, which essentially uses a magnetic to generate an electrical current that stimulates an area of the brain that we think is part of the circuitry that's responsible for OCD symptoms. So that is one option. There's also, like I mentioned, other more invasive treatments like deep brain stimulation or neurosurgery for OCD that are really reserved for more severe symptoms. There are also some newer techniques that are coming out, including both low intensity and high intensity focused ultrasound. Those are really under the research auspices and experimental right now as options. There's also something called direct current stimulation, which is again kind of, I would say, under research umbrella as a possible treatment. These are all kind of Some of them are non-invasive, some of them are more invasive treatments for OCD. I'm happy to expand more on these. There's other treatments that have, again, are kind of more experimental. Ketamine is used for depression treatment. I have a lot of patients, especially those who have kind of exhausted some of the pharmacotherapy and behavior therapy options, and they've gone on to ketamine. I think there's mixed results there. It seems to work for depressive symptoms, but not always for OCD symptoms. Same thing for ECT, or electroconvulsive therapy, which has been around for a long time and is still used for severe depression. I have patients with OCD that have also tried that. Again, I think very mixed results. It's not always very effective for OCD, but can help comorbid depression. And then there's other kind of newer trials coming out with psychedelics and using those for OCD treatment that, again, are kind of under the research umbrella right now that show some promising results, because, you know, a lot of our medication treatments have been around for a long time. And while they do work for a chunk of people, there haven't been many fantastic development in terms of the pharmacotherapy side of things. So now we're moving more to device-based treatments and potentially other kind of medication or substance-based treatments for OCD. It's kind of a quick run through, but and I don't know if I missed anything, so feel free, Dr. Mancibo or Chapone, to jump in.
Yeah, on the behavioral one, there's not a whole lot that's new. There's more research or being done on newer types of psychotherapies like acceptance and commitment therapies. It seems to be very promising. The trials are starting to come out where that seems to be an effective approach to treating OCD. We've done some work on augmenting standard treatments with physical exercise. And so some patients do experience improvement in their OCD symptoms if they engage in regular physical exercise. That's about it in terms of what's new in this.
One thing I would add in general across the board is we're also, I think, moving toward trying to personalize treatment more and more. And that's what we've been trying to do that. But we've been talking about how OCD is so heterogeneous, but now really trying to dig down a little bit more and figure out what the differences are, because we don't think it's necessarily between these subtypes or these symptom presentations that we're talking about, but maybe there's some neurocircuitry differences that may lead us and push us in different directions with regard to personalizing treatment a little bit more so that we can improve those treatment outcomes, not necessarily always changing and getting new methods, but also using the methods that we have them or tailoring them in a certain way for an individual person, which we always try to do, but I think we're moving more and more in that direction now.
I don't remember who had mentioned it, but one of you had mentioned towards the beginning of the presentation about how symptoms of OCD in many people can ebb and flow, and that over time, you know, you may have experienced more symptoms here and not here. And per people who provided feedback into our panel, that can often come at times of stress. So are there other things holistically that people can do or advise their loved one or support their loved one in doing that can help them to keep those symptoms manageable?
No, it's tough. I mean, oh, go ahead, Maria.
I was just going to say, well, definitely under times of stress, things like self-care will sometimes change. So sleep, nutrition, that's always something to pay attention to. And a lot of people will experience more OCD symptoms when they're having trouble that or difficulties with sleep, or start to get so stressed that they are not, you know, eating properly, not getting exercise, those kinds of things.
I think too, just sort of being aware that these flare-ups can happen, because I think sometimes people kind of panic when the symptoms start to flare, like, oh no, it's going back to the way it was before. And so even just some like, you know, psychoeducation about like this stuff happens, it makes sense, you know, whether there's a trigger or no trigger, sometimes this stuff flares up, then let's remember the skills, let's get back into, you know, maybe do a couple booster sessions of the exposure therapy to kind of target this stuff and get it back under control, but to kind of remind the person that this is what OCD does, and they have been working on skills, and they got to maybe kind of be a little bit more mindful of doing them and taking good care of themselves and all the rest. And that, just to get the symptoms under control again, I think kind of panicking about it and will just make it worse. It's easy to do. Get caught up in catastrophic thoughts about, oh no, like this again. And so just sort of trying to step back and see it as, okay, it's just a flare and I can work through this. And then, it starts to feel a little bit more manageable again.
Right. And I agree with those. And I think that keeping in mind that stressors aren't always what we construe as bad stressors, but they could be kind of good stressors, right? So going off to college, having a child, getting married, all of those things, which we may think are happy things, and they are happy things for the most part, can still be a stressor and can kind of throw everything off. So like Dr. Mancebo and Dr. Chapone were both mentioning, kind of trying to also get ahead of the game. So when I see family members of patients with OCD or patients with OCD who are heading off to college, as an example, I'll say, okay, let's make sure you have those supports set up wherever you're going. Don't need them now. Let's get them lined up ahead of time, because then you'll have them there if you need them, and just for check-ins. So kind of, again, being aware that these things might happen, like Dr. Mancebo and Chapone were saying, and kind of being ready for it. And if you don't need that extra support, fantastic. But if it's there if you need it.
That's a good point. Thank you. I'm just going to let the attendees know. We've only got a few minutes left. If you have additional questions you'd like to add into the chat or the question box. And then the last prepared question that I had ahead of time was beginning with Dr. Mancebo, as you appear first on my screen. Would you provide in a brief summary sentence or two what you wish the general public knew about OCD?
That it is common, and that it is it can be so severe that it's like someone is trapped in this bubble of being tortured. And the way that one of my clients explained it to me once really stuck with me. Where it's this thought that pops into your head that just will not leave. And just imagine waking up every day and going to sleep every night, knowing that this is going to be there no matter what you do, where you go, you just can't get away from it. So it's incredibly distressing for people. And they recognize that it doesn't make sense. And so that's incredibly frustrating for people.
Thank you. Dr. Chapone?
Yeah, and that there's treatment, that there are people here to help. It's really tragic when you meet somebody who's been suffering for years and years, either just trying to white knuckle it through or deal with it on their own, or I've met a number of people that have been misdiagnosed, because even some treaters who don't specialize in OCD, they don't always recognize some of the symptoms as OCD, like harm obsessions or, mental images that can pop up, which we would say are obsessions, and people get confused and think they're, hallucinations or things like that. So they've been mismanaged, not gotten appropriate care, and have really suffered for a long time, who do great with treatment. And it's just a shame they didn't start appropriate treatment earlier on. So just to kind of know that treatment is available and can be really quite life-changing and helpful. So to reach out.
Thank you. And Dr. McLaughlin?
I don't have a ton to add. I agree with all of what they just said in terms of, it is fairly common, and it can be incredibly severe and really like something, is stuck in your brain and you can't get it to change. And just like they both mentioned, that there is helps out there. And, we have a great understanding of these thoughts. I've heard all different types of thoughts and compulsions from so many different patients, and that to be willing to talk about it with somebody that can help.
Great, thank you. I don't have any additional questions in the chat or in the question box. So I don't know if any of you all have additional comments that you'd like to make. Anyone?
Thank you for inviting us.
Yes,
thank you all very much for participating. I think this has been really helpful, and it'll be a great resource to live on our website for our members. And I appreciate you all taking your time today to share your expertise with us.
Thank you.
Thank you.
Thank you to everybody. Take care. Have a great day.